Okay, and I would like to move to the Medanta Hospital and the Lucknow. Dr. Goel? Okay.
Yeah, good morning.
Good morning. Good
Dr.
morning.
Nagamatsu?
Yeah, good morning. Good morning.
Yeah, Dr.
Goel.
Pratap.
Dr. Goel.
Oh,
Yeah,
okay,
Dr.
so
Hamasaki and me and the
welcome to
chairpersons.
Lucknow. Yeah.
Good
Yeah.
morning, Dr.
So
Goel.
my team is here. I have Dr. Danish, senior consultant with me, Dr. Vaibhav, who's a consultant with us. So, and then we have Mr. Puneshwar, the in charge of the cath lab, Mr. Iqbal. And we'll show you the case. I think, Danish, you can show the case. We'll show you the case first.
Yes, please.
Can you
go
get
ahead.
the slides, please?
So we have this 55 years old male with us. He is a long-standing diabetic patient and also hypertensive. He had an anterior wall MI 1 month back, and he came to us with that. ECG showed fresh MI changes with ST coving in V2 to V6. Also had small QS in 2, 3, and AVF, suggestive of probably old MI in inferior. So here we play the diagnostic angiogram of the patient, which was done earlier.
So
This
that's
was
the ECG shows, and that's the diagram that we make, showing the LAD, 2 levels of
Diagnostic.
disease and RCA 100. So you can see the angiogram. This is what it was when he came in first time. So he had severe disease in the LAD at 2 levels. The RCA was blocked and filling through collaterals from the left system, the tiny, epicardial collaterals across the AV groove. Next. The same disease is seen, and you see the RCA filling through collaterals. Next, onwards, the circumflex system was okay. Please move forwards, yeah. And that was the RCA. So you have RV branch, and then it's occluded at that RV branch takeoff. And then there is some antegrade filling through bridging collaterals. And the distal end part is filling through the contralateral collaterals. Next, please. That's the right, that's the RAO view. And next onwards, so that was the stenting that was completed because we want the other artery to be done at that acute stage. And the LV was bad, mind you, so we have to always keep in mind the LV. I invariably do a LV angiogram so that I can see it always again and again and know how my LV is, because that is the brain of the heart. Okay, so with that, we planned for RCA to be done stage 2. So now we are here with the RCA, so the initial angiograms. So that's the, actually, move forward, please. So that's the SAL. I have a right radial and, can you show, and right femoral axis. I invariably do the main artery, the target vessel from the radial and the contralateral from the groin. So we have a 7 French, we have a glide sheet. Hold on, please. Please hold on the angiogram. So we have a glide sheet here, and we have a 7 French SAL that I have hooked. And on the left side, right now, I have only a diagnostic left angio. I can explain you that why I have only a diagnostic as of now. So seeing this, well, I don't know if you want to discuss, or I can tell you, because of the side branch and bridging collaterals, and which is filling the vessel antegradally, the plan here, for me at least, was that I will do antegrade wiring by IVUS guidance. Because with IVUS, we can see the stump, and then do the antegrade wiring. Because the left, and because the distal artery is good, if I fail, the second would be ADR, and retrograde, especially with that AV groove collateral and thin ones with little tortuosities, I have kept that as the last. So that is why I only have a diagnostic diagnostic catheter on the left side. So with this, by the time we are waiting, I have done something I can show you. If you want to discuss or I have a question, I would be happy to answer, and then I'll show you where we are, what we have done.
Okay. Okay. And thank you very much the case presentation, Dr. Goel. And in this time, we would like to discuss about the procedure. And do you have some comments from panelists?
Dr. Goel, good morning. I'm Dr. Raghav. What I want to ask is, do you think it's a bridging collateral, or is it a vessel which is like that only after that branch? Because if you see in dual injection, it looks like a continuation going
the
up.
angio that is running right now also, if you see, there is a very tortuous vessel which is connecting to a straight distal vessel. So that is a bridging collateral. You see, the vessel is straight above, straight below, so you can't have that bend, you know.
Okay.
So that is a bridging collateral, and we always see
Dr. Goel, this is Vivek Gupta. I also felt the same thing.
So the RAO view was also there. We can show you that also.
Okay, patient with Aleo.
Previous.
Aleo or the Aleo caudal.
Can you see in some other view?
And we talked to discuss about this channel
These are all
is here
bridging,
in the
you see there are
lumen
multiple
or the
bridging
bridge.
collaterals which are focused in the RAO view.
Yeah.
Okay? So with that, with the thought of doing with IVUS, so move forward, please.
Goel, can you stop for
So
1
that
second?
is the setup. So, yeah, please.
PK
Okay.
Goel, just Nagamatsu, if you see this approach of this case, actually with the side branch is there, a possible, there is a bridging collaterals are there, then how do you approach this case?
Okay. Anyway, we need more information. So still we doubt this route is here in the CTO or the bridge. And maybe the CT angiogram give us the good information that this route is here outside of the vessel or in the CT lesion.
Okay.
And another confirmation system is IRAS.
Okay.
IRAS. And from the and as you can see, there may be this CT lesion have the very nice RV branch in front of the CT entry. So the once insertion and IRAS. And then so this bridge is I don't know where this vessel is be in the CT lesion. We have the chance pass through this channel.
So you'll take an IVUS now.
Yeah.
IVUS now.
Yes.
Will you take an IVUS with your usual technique of dual lumen catheter with IVUS, or what you'll do? You
just only firstly we can do just only the confirmation.
Okay, that's all.
And actually this bridge is the diameter is very so nice. Maybe we have the chance insertion IRAS and with the confirmation for that this one is in the CTO region or not.
Dr. Vataru, can I ask you a small question? You have been talking a lot about CT coronary. So do you think that in all CTO planning, in most of them, you should have a CT also done before we go for it? That would help.
Yes. And in Japan, we can go to insurance, and we can check for the oral CT cases before starting the procedure.
So, Dr. Nagamatsu, do you think there is some partial channel possible there or not in this lesion? Near that point of CTO, do you think there may be a partial channel?
Maybe so. Actually, usually it be difficult to confirm this one is be in the CTO or not. But actually, this vessel, the diameter is quite big. Very easy way to confirm. Maybe
Actually, for
and in such a situation, one option is a chip injection.
You have to
chip injection.
You have to
using a microcatheter.
Can I speak, please?
Chip injection using a microcatheter can tell us big information in such a situation. Yeah.
Actually, the tip injection is a double-edged sword. It can tell you that there is a microchannel, but by the way, if you are not in a microchannel and you are subintimal, you can produce a dissection, and then something that you could enter much easily would become more difficult. So I personally do not advocate that, although rarely I have done it, but very rare. Okay, so you want me to proceed as to what to on the case? So that is the IVUS, and yeah, I am pretty sure there were at least 2-3 channels which maybe you can't see from that distance, but when you see the angiogram from a close distance, frame by frame, then you know that this is a collateral channel. All right? This is a bridging collateral.
Okay.
So that is how it was. So we did an IVUS. So you just move forward on the next frame of this angio. So again RAO. So biplane. And move forward, and that's the IVUS setup. Yes, show me the IVUS. So I'll show you the IVUS. So that is the IVUS from the RV branch. So you have the pericardium at 12 o'clock position, sorry, 6 o'clock position, and we are withdrawing. This is the withdrawal. This is the withdrawal one. Please communicate with me. Huh? So that's the withdrawal coming up. Keep moving forward. This is the first run. This is the first run, correct? So now this is the diagnostic, and now you will see the RCA coming. Just move on, please. So now you start seeing the RCA stump at 6 o'clock position. Can you see that? So that's where we want to enter. So we have identified that where the RCA, the native blocked RCA is there, all right? And with that, then next, so then now what I have, now because it is 7 French, what I have is only a single lumen microcatheter. A dual lumen could be used, but then you need a 8 French, okay?
Yeah.
And because I do majority of my cases radial, so then I can't put a 8 French through radial. So I have worked out my ways through 7 French, and I do it through a single lumen catheter, microcatheter. And can you, what is visible there? Okay. So with that, I used a Gaia 2 wire. Initially, I did try a XT. Can you stop it, please? I did try a XT to see if there was a channel and something would go, but the XT failed to go at all. It just stopped right at the mouth. So then the second thing was the Gaia 2. And the Gaia 2, now if you see, can you show the, now you see that wire is coming at 6 o'clock. You see that dense spot of the wire tip at the 6 o'clock position. So it is in RCA. It is in the native RCA of the block stump. So now I am sure that I have entered right. Once I have done this, move forward. Do you have another IVUS? You have another IVUS? So it's very clearly seen that I have entered correct. Okay? Now this is the only part that IVUS will be able to help. The movement beyond has to be all angiogram based, because the IVUS will always keep telling you that, because you can only see the mouth of that vessel, where you can't see the distal vessel through this IVUS. So it will keep telling you that your mouth-wise it is okay. Now, next please, angiogram. So now beyond that, you have to then move away from the IVUS. So now I have to angiographically advance it. So this was the Gaia 2, which was trying to be advanced, and you know it is not moving very well. Move forward, please. It is not moving very well. And, you know, because it's only tiny pushes, we can't, with that tactile feel, and it is not moving. So I wanted to upgrade the wire, and now you see the movement now? It is a little independent movement from the RCA stem.
So Dr. Goel, how does it look in the RAO here?
I'll always do biplane. Always. So you see it there. In RAO, it looks straight, but in LAO, it is moving independent of the RCA. That is the parallax. And if it is moving independent of the distal RCA silhouette, that means it is probably not going in that direction. It is going somewhere else. Although the IVUS will continue to show that the mouth, it is inside in the true site.
That means after entering
so
into
now
the
at this stage, now you see that there is an independent movement of the tip. It is not correct. You are seeing the distal vessel there, but this is not right.
I think you have to
So
pull
with
it a
that
bit.
movement now, I don't want to proceed further. I did not want to proceed further and create big subintimal spaces and hematomas, because as I told you, my last strategy in this case is a ADR, if I don't succeed here. So next, what I thought was, what will we do? We'll do a parallel wire. So leaving that there, now the IVUS will come back, because for parallel wire I needed a dual lumen catheter. So next please, so the IVUS comes out, next please. IVUS comes out and the dual lumen, the crusade comes in. And now we are doing the parallel wire, so you can see the live fluoros of that. So this again, it doesn't look very good. Next. Yeah. And now for parallel wire, what I have is a Gaia 3. Because always, in principle, parallel wire should have a stronger wire than the previous one. And something which you can maneuver in direction. Next. Okay, so some progress, and now I see it in LAO. It looks okay with the tip directed posterior. Can you show me in the other view? Next, please. Next, I think RAO should come. Next. Yes, because this antegrade wiring is invariably biplane. Now you see here, the tip is directed posterior and away from the RCA. So what I will do is, I will rotate, this is 3D, the basic 3D wiring concept. I rotate it and make it forwards in this RAO view. Next, maybe in the next one I have done it. And then push this forward. This is the last where I am. Can I see it where I am? Yeah, so that is where I then pushed it forward. I used the 3D wiring concept that I was talking yesterday. Come on, angiogram please. Because you know, contralateral doesn't fill it very well. Let us see from the contralateral side. Yeah, so that is
Dr.
where
Goel,
I am.
let's say if you don't have a dual lumen
So
catheter,
this
then what
looks
will be
so-
your approach? If you don't have a dual lumen catheter and still you want to do a parallel wire, what will be
You
your
have
approach?
to have.
So sometimes
No,
you don't
no,
have,
no.
then
You have to have, sir. You have to have.
yeah.
Then I can't say.
Then
I don't do without dual lumen.
we'll
So
abandon
then
that case.
this is where I am.
Dr. Goel,
You see, because you
and
have
how,
to have the.
how about your
Can I
feeling?
see
Is
the
it free?
retrograde? Sorry?
Yeah, and how about your feeling? Hand feeling? Pass
How's
through
the
the
feeling?
this guide wire?
Looks okay.
Still subintima?
Looks okay.
Looks right?
I don't know.
No,
Let
looks
me see
fine.
where it is.
Yeah, it's good.
Free?
Yeah, I think
Good,
my
good, good,
feel is okay. That's where it is. Left injection, please.
Yeah, definitely.
I think I'm okay. Yeah,
Yeah.
that's it. Because finally it is the feel and the direction. Because
Okay.
actually antegrade procedures, I think, need a lot of this feel and skills.
Dr. Nagamatsu,
Yes.
one question.
Well, everything
Do you
needs
think
it, but this
the
needs
first
it a
wire,
little-
what he crossed using IVUS was
again, left
correctly
injection
punctured?
RAO.
I don't think so. The penetration with the first wire was not correct.
Yeah, IVUS is
IVUS
absolutely
Yeah,
correctly
yeah,
punctured.
looks
You must,
like,
anyone
maybe
who's
be
there and
intima.
who's wanting to
Then
learn,
I think he is
please
successful.
understand this is the absolutely correct puncture of the IVUS.
No,
But
I don't
beyond
deny
there is-
that.
Yeah,
sir.
okay, okay.
You have to
So
understand.
maybe that due to the calcified lesion, so I don't know where, but a little bit we cannot see the more deeper. And we have the chance, if we use a Nipro HD IVUS more, we can see the more deeper and with the good resolution. We have
advance this
we have to think about which IVUS is better for this procedure.
But Dr. Goel, Vivek Gupta, I should compliment
Okay,
you
where is
that
the
you have shown a very step-by-step approach to all the audience sitting here,
This is the side
especially
branch
when you
with the अटकी हुई जो है,
were offline.
इसको निकालना है.
Okay, thank
So
you very
this
much.
thing comes out.
And we would like
thing
go
comes
to the
out.
another room.
And-
A big congratulations, Dr. Goel.
And then
Okay.
Okay, so now you move to the other room, then I'll show you what happened now. Okay? Because I am through.
Okay.
Yeah, I'll show you. Can we go back to where we were?
Yes, please.
So, go back. Forward, forward.
So last time that you used a Gaia third,
Forward.
and this Gaia third, and
Yes,
get advanced
finally
to the
Gaia
distal
third
part
was
of
successful.
RCA.
Yeah, this is where
yeah,
we
yeah,
were.
Yeah, this one.
Yes,
Maybe
so
this
this is
picture.
where we were. Move forward. So you are grazing the inferior border of that RCA, but the field was okay, and the way it went, so I just moved it in front of you. Move forward, please. So it was, this one was going in a branch. Go back. And then I moved there. Okay? From the retrograde injection, you see in the stem it is okay. So I was confident that this is in. Next. So confirming it in RAO also. Always two views is very good, you know, especially when you're doing CTO procedures. I used to work in biplane in my previous hospital, but now here we have only single plane, so I have to adjust my things according to single plane. Otherwise, I always liked biplane. Next. So now we have pulled out the IVUS, and so with that wire, so a small 1.5 dilatation, and then we will change it to a workhorse wire. That's what I'm doing. We're changing to workhorse wire. And next. Forward karo. So then the balloon. I think that's pretty standard, so I wouldn't. Next. Then what we did was we did a IVUS post balloon also.
Excuse
see
me,
the size of the artery.
Excuse me, and
we
Dr. Goel?
Yeah.
And when did you
Yeah.
perform the IVUS, and before the using the 2.5? Or after that?
No, I did IVUS after doing 2.5.
After that?
Because
Okay.
the purpose of this IVUS was only to get the size of the vessel, you know.
Okay, and
to
then we
choose
would
the size
like
of
to
a
check
stent.
the route is here, bridge or in the CTO.
Sorry,
Okay,
I didn't get it.
anyway. Okay, please show me the IVUS
Okay, so
study,
move
and
forward.
after that
So you
use
can
the
show the
2.5.
IVUS?
Yes, we can see.
So you are seeing the IVUS. This is pre-stent, no?
Please
so this is the
explain this
pre-stent
IVUS image.
So the distal vessel is also good, 3.5, 3.8. So which doesn't look as much on this angiogram. So with that IVUS information at the back, we were confident to use a 3.5 stent here. Move forward. Then keep running the. So
Okay, and
so that's the proximal normal part. Okay.
excuse me. Now please show me the
All right.
IVUS again in the CT region.
Yeah.
Please go back to the more
In the
distal part.
distal lesion.
Yeah.
Yeah,
Not
run
distal
the
region.
IVUS,
We would like confirm in the CTO. And maybe we can see
Yes,
the 5
in the
to
CTO.
7.
Well,
yeah.
I was in the lumen. Yeah, you can see that.
Yes, now we can see the IVUS, but we would like confirm that in the CTO region.
Yeah.
Yes, and we can see the
Yes,
5
in
to
the CTO
7
part,
o'clock,
yes.
we can see the lumen. Maybe this one is a bridge.
Let us
Not
see.
bridge.
Just
Yes, I
before
think
we
I
get the
interfract
RV branch.
lumen.
Actually, I've
I
taken
think.
out the wire.
Yeah, maybe, yeah.
The
and
RV
even if the
wire
IVUS
has
are
been
big,
taken
using the
out,
book, but
otherwise we
still we
Yeah.
can see the big lumen.
There is some hematoma here. You see that? At 6 and 7 o'clock, there is some hematoma. 6
no.
and 7.
So this part is not CTO, I think. Okay, CTO. Oh, here.
6 and 7, there was
And
a
6
hematoma.
to 8. 6 to 8.
Yes, here you see the compressor.
Yeah. Yeah, 6 to 8. Yes.
Yes.
Maybe this one
Yes, so
is
that is
here.
the compressed.
Consecutively, we can see.
This
so
is where-
this is the root, right?
Yeah, so that is
Yeah.
what the CTO part
Was
was.
it a
there.
Okay, anyway,
Move
bridge
forward.
quarter in the CTO, I think.
Or was it a fenestrated?
Thank
it
you very
was
much
bridging
showing that this
collateral with
very
CTO.
interesting
That's-
iris image. Thank you
Yeah.
very much.
Yeah.
And what is
Yes.
the next one?
Okay. So we can see the final. Sorry?
Excuse me, sir. Please tell me the stent size.
3.5 years.
Stent size is 3.538.
Thank you very much.
Zines. This is 3.538 Zines.
Okay. Very
Good
nice.
result.
Very nice result. Congratulations, Dr. Goel.
Thank you. Thank you. Thank
Okay.
you.
Okay. And
Okay.
thank you very much.
So see you next IJCTO in
Okay.
Hyderabad. Okay?
Thank you very much. Congratulations.
Right. Okay.
Okay.
Bye-bye.
We would like to move to the another
Bye-bye.